Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all that ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in today to the Tate Chronicles. Welcome to this special episode. We are at HIMSS 2026 in Las Vegas, and we are live. I'm speaking with two guests. My first guest is no other than Christina Caraballo, who is the Vice President of Informatics for HIMSS. Christina, thanks for sitting down for 15 minutes.
It's nice to be here. Thanks for having me, Jim. Looking forward to the conversation.
I really am. So, they say everything old is new again. So we're going to have to start talking about interoperability again, because we haven't crossed the goal line yet with that. A lot of organizations say they are interoperable or they promote interoperability. But what they consider that goal and that functionality may be very different to what community, patients, and their families have. There seems to be a disconnect there. What's your opinion on that?
Yeah, interoperability. Still talking about it, right?
I know it.
When are we going to get there?
We're going to a long time.
We have been. Well, I think there's kind of two questions there. When we think about interoperability, there's internal interoperability within our own hospital system, and then there's external interoperability, how I share data with other people outside of my own system. And I really think that we need to start talking about internal infrastructure right now. We're seeing a data problem. Even if we have the infrastructure and systems in place where we can start to exchange data, not all that data is clean. I think we really need to start focusing on, like, how do we get clean, meaningful data to be exchanged so that we can act on it. And so that as we begin to develop more advanced modern systems that actually use artificial intelligence and other things, we're building on good, healthy, correct data and information.
So you're talking about at least internally having hygienic data, for lack of a better term, so that whenever it leaves that particular system, goes to other systems, it's clean data that's going out and being received.
Exactly.
Yeah.
And so that we have all the data. Right now, I mean, you've got a bunch of different systems like TEFCA and others that if you're querying for certain data, you may or may not get it back. I mean, there's so many just fragments that I think we need to really focus on. We'll dive into TEFCA in just a minute, but one of the things that was certainly required for certification of electronic health records, whether they're for primary physicians or large hospital systems, was the ability to set up file servers so that data could be kind of segmented into discrete areas, pushed to a file server. Third parties could ping those and pull back specific data. Are you aware if that's being used very much even? So when you say third parties, I'm thinking you're meaning like some of the consumer applications.
Right, Apple Watches, I don't know what. Yeah, all the consumer applications. Yeah.
Yeah, I feel like right now there aren't really clear. Well, within the hospitals, we go and we can log into our portals through our doctors, and many of them have them. So there's access points. And that's wonderful, but they're still fragmented. So if I go to multiple different providers, then I have to log into each of those portals. I personally go to George Washington Medical Facility in Washington, D.C., and I do all of my medical stuff there because it's on Epic, and I can log in and I get everything. So it's almost like I'm locked in, even though I live right next to Washington Hospital Center. I don't want to change because all my data is in the one place, and it's so inconvenient. I mean, not really inconvenient, but really? I could walk, but I choose to get on the metro because I have like my locked in data in one hospital system.
Christina, I have exactly the same thing in Chapel Hill, North Carolina, University of North Carolina Health System. All my data from everybody I see that's a part of that system is right there. So I'm a little hesitant, even though I might want to be going over to Duke. I'm not so sure how it's going to be easy to get that data from Duke into what I'm seeing, So, I mean, that's certainly, at that level, it's not even interoperable.
Yeah.
But kind of to get back to TEFCA, I know you've been really involved with individual access, I guess they call it, of TEFCA. That was probably part of the mandate.
Yeah, so individual access services through TEFCA, the Sequoia Project, which is the recognized coordinating entity for TEFCA, has been working on some work groups on individual access over the past couple months and has made some great progress. Recently, HIMSS was awarded a LEAP grant, which is leading edge accelerator projects under ASTP. And we have been tasked to make individual access work in TEFCA. We're focusing right now on key things like identity proofing, patient matching, implementation complexities. But the big thing that we are working on is how do we make this scalable so people can finally start having access to their information via TEFCA in a way that works well for them. We're in the early stages right now, but this is an accelerated project. It's a 2-year project. We're currently in the process of interviewing and doing landscape analysis, so collecting a lot of information from the industry, different stakeholder groups, HIMSS communities to better inform what we're going to do for our pilots.
Yes.
But after that landscape analysis, we're going to be working very closely with Meditech and Docket, which is a consumer app, and some of the QHINs to be identified still, to do a pilot program on individual access and really hope to start driving this forward. It's a big priority right now at ASTP.
I mean, for a couple of years, we've heard about it. I've been waiting on it. And so, I know that this may yet to be determined, but will an individual have to, in some way, sign up with one of the qualified health information networks, or will there just be some government access to TEFCA? Any idea about that?
That's a great question. Right now for our pilot, we're working with a consumer app. So that consumer application is going to connect into one of the qualified health information networks. I personally would love to see it so that we could actually get consumer apps to be able to plug into the network, because those applications are going to have more robust development, user interfaces that make it so that I can interact with my data. I come from, or started my career in a consumer app developer, and it was a ton of fun, but we couldn't get access to all of the information all the time. If we plugged into a hospital system, it was great, and we could provide a really great user interface for patients, and a lot of more innovative hospitals like New York Presbyterian and some others use that consumer app as part of their meet the meaningful use, view, download, transmit criteria, if you remember that from years ago. But I think that there's still some work to be done on being able to have those consumer apps really plug into TEFCA. But my vision statement is I would love to see where we could have really innovative applications be able to come into the network and have access to all the data to aggregate it for patients and their families.
Christina, let me tell you my pet peeve on interoperability right now.
Oh, yeah?
Under the, a decade or however long it's been, there was a federal government initiative that basically bought an EHR for every provider or health organization in this country. And then there were the regional extension centers that got paid to teach providers how to achieve meaningful use. I'm not aware of anything from a financial thing that will help motivate the adoption of actual use of interoperability. Is there? Could there be? Should there be?
What do you mean, the use of interoperability for?
Well, or that you have to be, if you want the federal government to pay for Medicare providers have to be hooked up to TEFCA and use TEFCA. But because they required that for electronic billing, if you wanted to build a government, you got to do it electronically. So they have done mandates. Will there be any kind of mandates for interoperability other than it's just the right thing to do?
Yeah, I think the information blocking rules are helpful because you have to share data, at least for the permitted use cases under TEFCA. But I do think we're making a lot of progress. I'm excited about the framework that we've got through the TEFCA, the national exchanges, and kind of where we're going. And it's promising that they've already got, I think the latest I heard was about 72,000 organizations of all types connected into the network.
Okay.
So I feel like if we keep just pushing, we'll kind of start to get to that point where data is actually being exchanged and there's tons of progress being accelerated. It's really... Oh, I just came from a HIMSS session where we heard from ASTP and CMS talking about like the roles of TEFCA and also like the innovation that is happening right now within the CMS framework that's happening. They kind of referred to that as an accelerator program.
Yeah.
So taking what CMS is doing and then feeding it back to other work that's happening. It's very synergetic, which is I thought was very interesting during that session to just listen to the discussion on how we're kind of continuing to move forward as a kind of community.
Sure. Christina, we're almost totally out of time, but before I let you go, if we go back in time and we made you the czar of interoperability and you could start it from scratch and build a foundation with what lessons we've learned and best practices we've been exposed to, how would that have been developed?
Yeah, that's a good question. And I feel like we've been here before where we just haven't crossed the finish line.
Yeah.
And to me, it's that robust system or of connected systems that I can get access to data when and where I need it with the ability to have very secure data. I do have concerns as we continue to accelerate that there could be bad actors. So when I think of an interoperable system that's perfect, I think of not only data flowing everywhere it needs to go, but in a very, very secure manner.
Yeah. Well, one of the other things that I've kind of been thinking about, Christina, there's a culture, the technology and the plumbing for TEFCA are kind of in place, but there needs to be a cultural shift. I read a history recently about stethoscopes. When the stethoscope was first invented, there was a lot of pushback from providers who didn't want to use a stethoscope. That's going way back. And then EHRs, and then there's certainly pushback now from ambient AI providers saying, well, no, but that's kind of, widely accepted now. But, for a provider, some providers, for their culture to change so that they trust that external data coming in and don't feel like they need to repeat the chest x-ray, that trust level, the trust of data, external data. Where are we on that? Do you have any idea or?
That's definitely huge.
Yeah.
I think you've nailed one of the biggest challenges that we have right now is trust and being able to trust that the data that I'm getting is good data and the data that I'm getting is can be trusted from the different systems. And I know we got the signal to wrap up, so I gave you a quick answer. We might have to be continued.
And we will continue this. Yeah, the trust is a big thing. The culture, that's beyond the technology. Christina, thanks for joining me on this episode of Tate Chronicles. We're live at HIMSS26. I hope it's a good conference for you. Thanks for stopping by.
Great. Thanks so much, Jim.
I enjoyed it. Welcome back to our live recording at HIMSS 2026. I'm your host, Jim Tate of Tate Chronicles, and my second guest is none other than an old friend, Timothy Bennett, the Director of Strategic Healthcare Initiatives for the Drummond Group. Timothy, we've known each other for quite a while.
Long time. We've been through quite a bit together over the years of regulation and all. I
can't even guess how many presidential regimes we've been through.
Quite a few.
Of every stripe. Okay, I know you're still, and we talked about this a little bit earlier, Tim. for the first time that I can recall in the certification process last 20 years, last year in 2025, based on some executive orders, things got changed mainstream. Demographics got changed. The requirements around real-world testing got changed.
Yep.
There's a government shutdown that changed the deadlines for some fire server upgrades, USDI version 3 and stuff. How difficult was that for at Drummond to support your customers through those changes?
Yeah, I mean, I think, it's interesting. There's a proposed rule out now, HDI 5, which is unprecedented amount of deregulation on, what they started way back with meaningful use.
Yeah.
And I think some of it is interesting. But, some of it is, are we going to see, EHRs to stop, supporting certain functionality? I would like to think not, but there's always the question if new folks coming in don't have to do what the old folks had to do.
Sure.
What does that mean? So I think there's a lot of questions. It's interesting. I do think the administration wants to move forward with, more focus on interoperability.
Yep.
And fire and other technologies, and because of, I think, certain executive orders within the administration, they have to deregulate in order to write new regs, and so that that causes a little bit of tension, I guess.
So, anything in particular you think we might see changing this year, or is it just too unpredictable?
Well, I think HDI 6 is going to come out later this summer. Mm-hmm. It seems to be, the rumor seems to have legs, which, I think will push the boundaries on fire and electronic prior authorization and those kinds of, technologies, which I think are good. But at the same time, I guess we'll see what happens with the deregs around HDI 5, whether they hold up or not.
Timothy, one other thing I noticed this last year, you and I have both been involved in the certification process probably for 20 years. Close to it.
Yeah.
A long time. This last year, some of the government developed testing tools didn't work for long periods of time. I had never experienced that.
Yeah. Well, and let me just say, those testing tools, they're good. They serve a purpose. They help to identify if implementations are compliant with standards. But I've been on a soapbox for a long time that, and I think the real world bears it out, is that even though a test tool might tell you that you're compliant to a standard, that doesn't necessarily mean it's going to work in the real world with other implementations if you're trying to exchange data. And so, my focus at Drummond has been to bridge the gap between conformance and compliance to a standard using these standard test tools, and then what does it mean to be interoperable in the real world, and how do we test to make sure that is, because those kinds of test tools, whether they are up and running and are working all the time or not, still aren't going to guarantee
absolutely
that fire implementations or other data exchange standards are going to be interoperable.
The requirements for certified technology certainly have changed over the years. As developers are given a list of requirements of functionality that their technology has to meet.
Yeah.
And so I would think, from what I've seen, Timothy, sometimes there is a focus on meeting those minimum requirements and not worry about best practices. And I think what you're talking about is how do those things kind of get buried?
Well, and that's right, especially if we're talking about some of these more complex data exchange standards. And I'm talking about fire, but even the business use cases, like let's just take prior authorization.
Yes.
Because that's top of mind for everyone right now, is that you can write the standards all day long and people can implement them and test them against a test tool, but because these are business use cases, typically in business workflows, and they're complicated, there is a lot of best practice around it if they're going to work in the real world. Yeah. And you can't ignore that. And the way, that you're going to figure out if these standards are going to work in the real world is you have to get everyone together to test. We kind of do that at Connectathons. And, some technology vendors and payers or providers are doing pilot projects around that to try to figure out if they're working. Mm-hmm. But we really need a systematic approach to that. One where we can sort of document what those best practices are. Yes. That this is what it's going to take for these business use cases to work in the real world. Yeah. That will be sort of adjacent to the standards. And that's what's kind of missing. And that's what keeps people sometimes working in silos, where you have one vendor that owns a whole section of a whole data exchange, part of the ecosystem. Sure. Because they can make it work, and they don't have to account for every variation, right?
Well, I know you are probably less than an hour away from doing a presentation here at HIMSS 2026 on fire interoperability testing.
Yeah.
Give me a preview of that. What's that all about?
Well, so it's basically what I'm kind of talking about. I've been thinking about how do we test fire at scale? How do we test fire in the real world? How do we guarantee that these complex fire use cases like prior authorization, you're going to have patient cost transparency coming down the line next, payer data exchange, all of these complex business cases. How do we know that they're going to work in the real world and not going to be just another black eye in the long history of health IT, not, solving problems and being interoperable? We want to make sure that these things work in the real world. And the way to do that is to bring together all of the implementations and have them test with each other at scale. And I'm not talking about just EHRs and payers, but all of the other entities that sits in the ecosystem, intermediaries, QHINs, HIEs, clearinghouses.
I know, Timothy. Well, you mean we can't hope that AI is just going to come in and fix it all for us? We're not going to have to dig ditches?
Well, so obviously AI does have a role. I mean, I think for some of these business use cases, AI will help make decisions on behalf of payers or providers. But that just becomes another component in the ecosystem. Is it giving the right answer for the question? The right question is being answered, right? And so. Whether you're using a structured rule set or whether you're using AI or someone has written a bunch of code that says, if this, then that,
if then,
it's just the concept is the same. We have to test to make sure that not only are we able to exchange data in a standardized way, but that the data is good, that the answers are correct for the questions being asked. That hasn't been part of testing yet at all.
Right.
And so that's what, at Drummond, we're standing up a thing called Fireplace, which is a place where you can go to test fire. You don't have to find your own test partners. We'll have payers, we'll have providers, we've got intermediaries, QHINs coming to test, and we're going to test the way it's going to work in the real world, and we're going to find out where the interoperability issues are. We're going to fix them, and we're going to build these best practices. This is what it takes for EPA to work in the real world, and for these standards.
How do vendors get involved with Fireplace?
Oh, well, Drummond, we have a website, so drummondgroup.com/fireplace.
Okay.
And you can go from there, or send me an email at timothy@drummondgroup.com.
Sure. Something else we kind of mentioned earlier, it seems like the current move in terms of certification and documentation is around interoperability. The real world testing, so they look like that's been hardened around. I kind of wonder if the definition of a base certified EHR is going to change or go away, because right now, affordable care organizations, if you're going to be hooked up with them, you have to have a base certified EHR, and so I wonder if the definition is going to change.
I think it has to, because, when we're talking about the fire space like this, I think you're going to have specialized pieces of software that are just going to do certain functions or tasks, and they play a significant role, but they're not going to be able to implement or certify to all of the different kind of technology options. So I do think that there has to be some different way of thinking about how certification happens, and that. So, we're taking the approach of, when we're testing and certifying fire technology, we think about it at the fire capability layer. That, you may have an EHR that implements a lot of fire capabilities, but you might have specialized products that only do DTR, and they may only do CRD, parts of the workflow.
Sure.
And so they have a limited set of fire capabilities, just the stuff that they need to do, the specialized part that they need to do. And I think we need to recognize that, support that, promote that, because I think that's going to be, moving forward. I think that's going to be a big part of how software is built.
Timothy, we're already out of time.
Yep.
It's that time we strike the tent and move on. Thanks for spending a few minutes with me at HIMSS26 Live from Las Vegas. You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.